So what you've alluded to is called, in public health we call it the epidemiological transition, and it's when a country moves from developing status to developed status, or if the people in the country progress socioeconomically. And the assumption is that's a gradual improvement in quality of life. And it's been a bit of a stop and start in South Africa. After 24 years of democracy, we are still one of, if not the most unequal countries in the world, after generations of separate development. And so in the 90s, you see various epidemics becoming established in South Africa, obviously the most important being HIV. HIV ravaged the country. We peaked with prevalence in about 30%. And so even though we had come to democracy as an upper middle income country, we had high rates of infectious diseases, and bubbling under the surface was always a growing prevalence of non-communicable diseases. So whereas in South Africa, whereas in the rest of the world, you might see a shift, and a clear shift between decreasing infectious disease and increasing non-communicable disease, in South Africa we really see an overlap, where up until 2005 we had increasing mortality due to HIV and TB and all the other communicable diseases. 50% of our population died due to communicable diseases in 2005. And we've seen a reversal of that now. So now 50% of the population dies due to non-communicable diseases. Non-communicable diseases, unfortunately, the old way of thinking about non-communicable diseases was that it was a disease of rich people. You get heart disease, you get diabetes, hypertension, because you were living the good life and you had access to food and all of the good things. That's not the case here. People who are developing diabetes and hypertension are generally the lower income classes. It is very difficult to get access to fresh food, healthy food. It's actually more expensive than highly processed food, which is high in starch and fat. And so non-communicable diseases are actually moving in tandem with our infectious diseases. We're trying to curb those, but whereas other people might call it a transition, we probably would call it a collision of non-communicable diseases and infectious diseases. So people are exposed to high sodium diets with high fat. There's a high incidence of smoking, especially in Cape Town, the Western Cape, and obesity, which is sort of that intermediate stage before you develop cardiovascular disease, diabetes, and hypertension. It's estimated that 50% or more of our women are obese, and 30% of men, which is that's a time bomb. It's waiting to erupt.
So there's definitely been more government-driven education, so more advertisements on how to prevent hypertension, what diabetes is, those kind of things, which we didn't have actually a few years ago. So there has been a sort of a shift in that way, that people are actually being educated now. There's a lot of things about health insurance, if you have chronic lifestyle diseases and all of that. So there is a lot of help given as well. We aren't at a place yet where we can say everybody knows now, what those things are. But hopefully we will get there.
I think we're not doing enough about prevention and health promotion. I think we're trying to tackle it too much on a curative basis. So we're waiting till people become ill before we intervene. So people first get diabetes and then we treat them, rather than preventing them from getting diabetes in the first place. So it's possible to think about it in terms of a population that we know, who are known patients already, right? The known diabetics and hypertensives. But beyond that is a population at risk of the same diseases, right? So the easy place to start is in the people who are at higher risk. It's not just about knowledge, it's about the accessibility of the foods. of the right foods. So what you've got to understand is that the food companies are pushing profits. They want to make profits.
Yeah.
And that's a massive industry with all its advertising, etc. You know, Coca-Cola, all the junk foods, etc. is being pushed on a population. And whatever government is doing by comparison is a tiny little, you know, what we say, whistling in the wind.
Yeah.
By comparison to this whole marketing machine that is pushing unhealthy foods on people. So it's that kind of, you know, mismatch of the messages. So whatever you say is in the context of its massive advertising campaigns to get people to buy junk food.
So, unfortunately, what you'll find is in the private and public sector in the country, they have vastly different amounts of money that are provided to them. So we have 55 million people, 56 million people in the country. Of that, 84% access public care and only 16% go to private. But the same amount of money, which is about 4% of our GDP, goes to each. So 16% of people are getting 4% of GDP for health, and 84% of people are getting 16% of GDP for health. And so because of that, you see the public sector is drowning. They don't have enough resources, they've got excess patients, they don't have enough staff. So a routine checkup for diabetes, you need to look for microvascular complications and macrovascular complications of diabetic vascular injury. Right? To do that effectively, you need time with the patient. You need to obviously do the vitals, you need to do a fundoscopy of the eye, you need to do a dipsticks for the kidney to check for protein in the urine, and you need to actually take someone's shoes off. You need to look at their feet and you need to examine to see if there's any ulceration or any evidence of a diabetic foot. Now, to do that properly and to assess adherence to medication properly, you need to spend, I would say, at least 20 minutes to half an hour with the patient for the basics. In our clinics, a junior doctor is expected to see at least 20 patients a day, and a senior doctor between 50 to 100 patients a day in 8 hours. They've done studies in South Africa to show that we only get about 4 minutes per patient, and then you can't do a full comprehensive check. And if a doctor is seeing a patient for 4 minutes every 6 months, the quality of care that they receive is not going to be of a sufficient standard to prevent them from going on to develop frank diabetes, heart attacks, and stroke. So yes, there's a big difference. If you're in private, you have access to funding. You would probably be able to see a specialist without needing to be referred. You can go directly to them. You can spend half an hour to an hour with that specialist every 6 months and have access to care. I mean, we still have the same medication, we still have specialists, we still have the same drugs, but the system is overloaded in the public sector. It's much easier to treat infectious diseases than non-communicable diseases. Because with your infectious diseases, you have a necessary cause. So any infection, you have a virus or a bacteria or a fungus. You need to find that, give the treatment, and you're sorting that out. Unfortunately, with the non-communicable diseases, you can treat, but if you don't address the underlying risk factors, and that's diet, education, exercise, and which relies on personal behavior change, and that contact, that quality contact with a healthcare professional that can take you through that behavior change, it's very difficult to actually cure someone of a non-communicable disease.
So this hospital is obviously a tertiary hospital. It's a government hospital, so it's public, which means anybody can come. It's usually people around the area, so it's a drainage area, so anybody in the southern suburbs is allowed to come to Fritske. So we definitely have excellent doctors. We definitely have an excellent facility. It's just the patient burden makes it difficult to give everybody the best that we can give all the time. obviously we do our best to stabilize, we do our best to prevent further damage. We obviously do our best, but patient population makes it difficult. The burden of disease here makes it difficult to fully treat someone to the best capacity we can. We do have the resources, maybe not as many as the first world country, but we definitely do have the resources to do it in terms of facilities and equipment. But in terms of staffing, maybe not.
There's a lot of lifestyle changes that could be implemented, specifically with regard to diet. I think diet's the biggest problem. So we have high sugar, high fat diets that are cheaper, so people are becoming obese, and that's a major problem. And then there are the other issues of smoking, of lack of exercise, largely sedentary lifestyle that contribute to chronic disease. And there is a growing awareness that people should eat less refined carbohydrates, less sugars and sweet things, but it's in a minority of the population. So we've got quite a problem of obesity, including in children. There are other ways that we are working with at the moment at a local level with community health workers, and getting teams of people to work with specific populations who are at risk. So there are various models to do that. One is through work-based, employment-based programs. So you can influence people through their workplace, and that's a particular population. Or you can go geographic residential area by area, which is where the community health workers are. And that also works.
So, a few points. The first thing is that we're moving towards prevention. And we have to move towards prevention because with non-communicable diseases, you can either prevent at minimal cost per person, or you can treat and rehabilitate at maximal cost. The second point which we're trying to implement is comprehensive holistic care. And that's meaning care at primary level, which is able to meet you where you are in your community, analyze what kind of risk factors you are exposed to, and give you the tools to change your behavior, which is quite difficult for people who are locked into low income lifestyles because they're not conducive to health. And then the third thing is to actually make our healthcare service firstly well resourced with NHI and universal health coverage, but also efficient in the money that we get. So what we are trying to do is apply the lessons we learned with our HIV programs into non-communicable disease programs. We need to know how many people have non-communicable diseases in the community, how many people are on treatment, how many people are controlled on treatment, and what are the factors that increase good diabetic control, good hypertensive control, and how do we then expand that across the country. And it requires us to have good data systems, it requires us to have enough human resources, it requires us to have enough finances to pay for our drugs and our facilities. And we're hopefully moving towards that system with the National Health Insurance.